Hello, everyone, and welcome to the second Society for Skeletal Radiology Resident Education Club webinar. My name is Drew Ross. I'll be the moderator for this session, and just a couple of housekeeping things before we get started. First of all, take a look in the chat and you'll see information there about logging into Poll Everywhere. So there's going to be some interactive components during the webinar with some questions that you'll be able to respond to using Poll Everywhere. So take a moment to get logged in there and then you'll be ready to go when those come across later. Also, we welcome questions during the presentation. And for that, if you use not the chat function, but the Q&A function in Zoom to enter your questions, and we're going to pause periodically and get some of those answered as we go rather than wait until the end. So feel free to put questions in as we go in the Q&A function in the chat. With that taken care of, it's my pleasure to introduce tonight's speaker. We're very lucky to have Dr. Lindsay Stratchko from the University of Wisconsin presenting this webinar. Dr. Stratchko has a unique set of skills in the radiology world. So she completed her MSK fellowship at the University of Wisconsin, but she's also fellowship trained in interventional radiology. So she brings a really unique perspective to performing MSK interventions. So we're very lucky to have her to speak here today. And with no further ado, I'll turn it over to you, Dr. Stratchko.
Thank you so much for the introduction. I'd like to also thank the SSR and the Resident Education Committee for the opportunity to chat with you guys today. And thank you all for taking time out of your busy schedules to join us. Hopefully you'll find some great tips and fun cases to go over. So today our talk is going to be focusing on shoulder injections and interventions. And getting started, let's see here. All right, here we go. So the goals of our talk today is to discuss techniques for performing injections as well as aspirations of the glenohumeral joint as well as the subacromial subdeltoid bursa. And we'll be talking about several modalities, both ultrasound as well as fluoroscopic guidance. And what I really hope we get through today is to review the relevant anatomy in regards to our procedure, and then also go over different case unknowns to kind of help solidify different pathology. All right, so first starting out, we're gonna talk about glenohumeral joint injections, focusing on fluoroscopic guidance. And with that, we're gonna head into a question. So just a little bit of an intro here. My question slides are here, and then we'll go to our Poll Everywhere slide. And each Poll Everywhere slide has about a 15-second timer. So if you haven't, I'm just gonna give everybody a couple seconds to sign in here while we're discussing this, and we'll go to our Poll Everywhere question next so that we don't time out. So our first question, though, is when performing a fluoroscopic guided anterior approach glenohumeral joint injection, what position are you going to be placing your patient's arm in? So A, we're going to think about pronation, B, supination, C, abduction, or D, flexion. I'll just give a couple seconds here before we go on to that Poll Everywhere slide. Alrighty, so feel free to either text your results in or go to the Poll Everywhere app, and we'll go over the results in just a second. Okay, so the vast majority of people voted for B, supination, which was the correct answer. So moving on to kind of patient positioning and our procedural preparation. So as most of you guys noticed and answered correctly, we're going to be positioning our patient in a supine position because we're going to be doing an anterior approach. Our arm is going to be by the side and patient's arm is going to be supinated as well. That places the glenohumeral joint in slight external rotation and allows easier access to our typical approach, which is going to be a rotator interval approach. If patients are having a hard time remembering to keep that arm supinated, we'll typically place a sandbag on their palm or on their forearm to keep that position so they don't have to think about it quite as much. Regarding the procedural preparation, so certain things you'll need to be able to perform our glenohumeral joint injection. One is skin anesthetic if you want to be nice to your patient. Second is going to be contrast, and then your injectate, which we'll discuss the specifics of what we include in our injectate mixture in just a little bit. Certainly, we're going to need some needles. We will typically, whenever we're doing different joint injections, At UW, we'll often use a really small 30 gauge 1/2 inch needle, which you can see above the gauze is that left-sided needle for skin and anesthetic. We found that our patients typically find it more comfortable to use that rather than going straight to your 22 gauge needle. Then obviously we're going to need to get a little bit deeper, which is usually for a glenohumeral joint, an 1.5 inch needle is more than sufficient. But certainly if you have a patient that's a little bit on the larger size or has really muscular deltoids, you may have to end up going to a 3-inch needle for your injection. All right, so talking about the injectate mixtures. So obviously we're going to be having steroids. That's going to give the longer duration of pain relief for our patients. But in addition, most places will put local anesthetics in addition to that steroid preparation. And this is just a table of different common local anesthetics, as well as kind of how fast that they work and their duration of action. So it's important to note that local anesthetics can or have been shown to produce chondrotoxicity, which is both time and dose dependent, but it's very uncommon given the 1 to 4 milliliters that it's typical in an injectate mixture for a joint injection. But it's also really important to think about that the addition of epinephrine can significantly increase that chondrotoxicity. So if you're using lidocaine or some sort of local anesthetic with epinephrine in your subcutaneous anesthetic, you should really take care not to get that anesthetic inside the joint to decrease the risk of chondrotoxicity. Okay, and so this, I know it's a busy table, but I think it's a really useful table. We've compiled a list of some kind of common and more common and less common joint and injection cocktails. So what I have highlighted here is what our typical shoulder joint injection cocktail is, and that's typically a particulate steroid, which is Kenalog, which is mixed with both 0.5% ropivacaine as well as 1% lidocaine.
And I was just going to say, this is a busy table. It's a familiar one because we have this posted in all of our procedure rooms, and I look at it just about every day. But what we can do, so you don't have to frantically screenshot this, is I'll put some links to where you can access this table online. On Twitter, we'll get SSR to retweet those. So if you don't already follow SSR on Twitter, you should. A lot of great content. But if you want to get a copy of this table online, take a look at their feed later this evening, and we'll have that accessible for you.
Awesome. All right, so now after we've talked about the preparation, we're going to be focusing a little bit more on your injection approach and technique. So this brings us to our next question. When you're using a rotator interval injection approach, which target would you choose? And the image will not go over onto the poll everywhere question next, so I'll just give a couple seconds, then we'll switch over to our poll. I should have put some good wait music for you guys. Sorry about that. All right, so our responses were largely in favor of choice C, which is also correct. You guys are really great. So there's different injection approaches here. All can be used under fluoroscopic guidance, but certain ones are for different joints. So A is for a acromioclavicular joint injection. B is a fluoroscopic approach if you were to perform a subacromial subdeltoid bursa injection. C is our rotator interval approach to the glenohumeral injection. And D is another known approach for glenohumeral injections. It's known as the Schneider approach. So when breaking down those specific glenohumeral joint injection approaches, I think it's really important to look at your anatomy in relation to what we're seeing on radiographs. So here's just a normal AP view of the shoulder with some of the osseous structures listed for you. So you can see that the joint capsule is outlined here. So some other important anatomy when we're thinking about these joint injections is one, the long head biceps tendon. It will run through the rotator interval. And then when we're looking at the pertinent rotator cuff tendons, you've got your supraspinatus tendon, which is going to run above your coracoid process. and then your subscapularis tendon, which is going to run below. So then if we superimpose those different approaches there, you can get a better idea of kind of what anatomy gets traversed depending on what approach you take. So one of the things that I like to think about when I'm marking and prepping my rotator interval approaches is to really use that coracoid, because that's kind of the landmark for what your anatomy is. You know, your supraspinatus is going to be above the coracoid in your subscap. So as long as you're marking the humeral head kind of within the confines of the coracoid process, you can be pretty confident that you're going to be within that rotator interval. So looking at the rotator interval approach, which is in yellow, you can see, because we have less anatomy to traverse, it's more superficial. So sometimes you can get away with a shorter needle, and often it results in more patient comfort because, again, you just have less anatomy that you're going through. In contrast, the Schneider approach, which is the red kind of bullseye there, you are going to be going through some more anatomy, which could be a little bit more uncomfortable for the patient. And particularly if you kind of look at those layers as you go through, you have to go through the subscap, and you can also end up going through IGHL, and depending on where you're marked or where you're positioned, the anterior labrum may be in close proximity.
So, Lindsay, I had a question for you, because I learned first with the Schneider approach and then switched to the rotator interval, and that's what I've used ever since. And it works really well. Do you still find use in any circumstance for the Schneider approach? Is there anything that you find useful for?
Yeah, that's a really great question. And I would say my practice now is, almost exclusively a rotator interval approach as well. But I do find that particularly if I am asked to do a shoulder aspiration, a Schneider approach can be really helpful. If you think about kind of the anatomy, and if you're going to be coming down a little bit more inferiorly, you're theoretically going to be in a more dependent portion of the joint. So it may increase your ability to get some fluid back with an aspiration. So typically those are the times when I am considering a Schneider approach over a rotator interval.
Yeah, that makes sense. I think I've done that too. It sort of feels like you get more in the dependent part of the joint. And if you're trying to get fluid out as opposed to putting steroid in, that makes sense that would kind of be more effective. Okay, great.
Yeah, certainly. Awesome. All right, so here we go. All right, so now that we've kind of talked about the basics with patient positioning, medications, prep, and where we're going to mark, just briefly going over the steps of glenohumeral joint injection. Like we talked about, we're going to position and mark our patient, as well as prep and drape. So one thing that I like to do, I know it adds another tap on fluoro, but particularly if you have an anxious patient, is to just check your positioning right before you start numbing, because you may not notice it because you're drawing out medications, things like that, that the patient may have moved, shifted, changed the position of their arm a bit. And it really helps sometimes to be able to check before you start numbing, only to realize, if you didn't, then you may have to start renumb somewhere else. So after that, we're going to give our local anesthetic in the skin, and then advance our needle into the joint and confirm location with contrast. So there's certain contrast patterns that give us a lot of confidence that we're intra-articular. So one, if you get this kind of linear contrast that parallels the humeral head, you can be very confident you're going to be within the joint. The joint injection itself should be very low resistance. So that's kind of one tactile thing that you can think about as you're injecting. If you find that you have a lot of resistance, then likelihood of you being capsular rather than intra-articular is higher. So just be cognizant of your contrast, and then also how much resistance you're placing. So another place that contrast typically likes to go when you're doing glenohumeral joint injections is the superior subscapularis recess. And that you can see by some contrast kind of hugging the inferior border of the coracoid process there. So all of those very normal. And again, the contrast isn't pulling at your needle tip, it's flowing away freely, nice and low resistance. So in contrast to this, I want to show you kind of something that's more capsular, or not intra-articular. It can look kind of similar, but you can see the red arrows here are pointing to some very linear and kind of streaky contrast. And you can notice that if you inject more, or particularly if you're injecting your steroid mixture, it doesn't kind of wash out or dissipate at all. So those really are kind of more capsular contrast patterns rather than intra-articular. And again, oftentimes you're going to have a higher resistance when you see a pattern that's similar to that. So after we've confirmed that we're in the joint in a position that we like, we're going to go ahead and inject our steroid anesthetic, remove, cleanse, and dress.
Lindsay, I had a quick question before we move on. Someone was wondering if you're not able to see the coracoid process well for whatever reason, the patient's kyphotic or a lot of degenerative remodeling or whatever, are there other landmarks that you can use to get your needle through the rotator cuff interval approach if the coracoid's not working for you?
Yeah, so I think that's a great question. And I think oftentimes it depends on whether or not the patient has some severe rotator cuff arthropathy or not, because I'm sure you guys have seen radiographs. If a patient has a full thickness superior rotator cuff tear and their humeral head's really high riding and kind of abutting the inferior surface of the acromion process, it can really kind of distort your anatomy and make things a little bit challenging. So outside of that circumstance, if you have a relatively well-aligned glenohumeral joint, what I like to do, kind of, you can actually see it on this slide here, is there's this little crossover point kind of between the humeral head and the glenoid. So one, I kind of use that as my starting point and then come a couple millimeters lateral, so kind of along the humeral head, which is a nice anatomic landmark. And then you can also confirm that if with the coracoid, if you can see it well. And then the other thing is too, if I do have a patient that has bad rotator cuff tear and a really high riding humeral head, if the patient can kind of relax their arm down, I find that can often be helpful to kind of bring everything into a somewhat more of an anatomic alignment. But even if that's not the case, I'll still try and maintain more of my glenoid landmarks rather than kind of high up on the humeral head, which I found to be pretty helpful.
That's great. That's super helpful. We had one other question pop in, and then I'll let you move on. Someone's wondering, are you setting this up as a true AP or as a Grashi when you're setting up your view for the fluoro injection?
Yep. So when we are having our patient in their position with their arm by their side and supinated, then I'll typically have my II just a straight AP to the patient. So when I'm advancing my needle, it becomes really easy because you don't have to induce any angles. You can just essentially advance your needle perpendicular to the table, which again, kind of makes things straightforward. So kind of a straight AP to the patient once they're set up. All right, so moving on to our next question here. So while injecting contrast during a glenohumeral joint injection, you notice some contrast in an abnormal location. And I'm sorry, my arrows didn't come over. So I'm gonna put my pointer, hopefully you guys can see that, on the contrast here. And what I want you to do, so what's the diagnosis? So A, a full thickness rotator cuff tear, B, subacromial bursitis, C, adhesive capsulitis, or D, a labral tear. Oh, I'm seeing that you can't see the arrow. So here, I'm going to see if I can come back one. So I apologize, you can't see my arrow. So if you're looking just cranial to the needle, you can see some dark contrast that's above the humeral head that's extending kind of up towards the acromioclavicular joint. So again, I apologize, those arrows didn't come over, but we'll go ahead and go to that poll everywhere question next. All right, so you guys are great. So this is a secondary sign of a full thickness rotator cuff tear. So some of our other findings would be challenging to see. So again, typically not going to see too much of for subacromial bursitis, particularly if the rotator cuff is intact, because they're going to have the rotator cuff separating your bursa from the actual joint itself. Adhesive capsulitis can be a tactile sensation when you're doing these injections. They can be a higher resistance injection just because the capsule is not as capacious. Labral tear, we're typically not going to be seeing too much of that on our initial like arthrogram or arthrographic images. But this is actually a case of the geyser sign, which we can see on multiple different modalities, and patients can present in a variety of different ways. So it's always good to keep an open mind about what could be going on when you're dealing with a patient. So as we talked about here, the geyser sign is an indirect sign of a full thickness rotator cuff tear. And that's when glenohumeral joint fluid communicates with both the subacromial subdeltoid bursa, as well as the acromioclavicular joint. And that's again in the presence of that superior rotator cuff tear. So the image on the left, you can actually see that there's soft tissue swelling over the patient's clavicle. So again, they may be referred to you for a palpable mass or a lump that they come to you for ultrasound for. Again, we have our fluoroscopic image here where you can see that contrast that extends up into the AC joint. And the image kind of on the third image is an AC joint ultrasound where you can see that there's this anechoic cystic structure that's just superficial to the joint or the AC joint. And then the image all the way on the right is just an MRI showing that this patient, the yellow arrows are pointing to a superior rotator cuff tear, a high riding humeral head. And then again, you can see that nice cyst that's communicating that joint fluid up through the AC joint. All right, so another question. During your injection consent, your patient states that they have severe allergies to both gadolinium and iodine-containing contrast. What are your options? So A, there's no options, who can't undergo an injection. B, perform an injection under ultrasound guidance. C, perform an injection with air arthrogram. Or D, perform your injection with OmniScan. And then E is B or C. So we'll head over to Poll Everywhere here. All right, so great. So the correct answer for this one was B or C. So there are some options that we have for patients who have contrast allergies. You know, obviously, it's helpful to try and identify those things so that if you can pre-medicate or prepare prior to the injection, that's helpful. But if you do find yourself in an instance where a patient can't have contrast, either gadolinium or iodinated contrast, there are ways you can get around that. So an air arthrogram is a pretty effective technique for confirming, intra-articular location. So places where I find it to be particularly helpful is patients that have allergies. So if they have an iodine allergy, then my typical go-to will be GAD, and it's not going to be quite as dense of a contrast, but you can still confirm your intra-articular. If they have allergies to both, an air arthrogram is a nice technique for that. Where I find it actually the most helpful often is if I'm asked to perform an aspiration and my initial attempt at aspiration doesn't yield any fluid. And so what I found it to be particularly helpful because one, it confirms you're in the joint, so you can document that. But then also two, one of the things that the orthopedic surgeons want from that aspiration is the cell count. So anytime you introduce any sort of, saline, contrast, lidocaine, whatever, into the joint, it can dilute and have an effect on that cell count. So it's a way to potentially clear your needle hub, increase your likelihood of getting fluid back without having to inject any fluid into the joint. So I do have to give a caveat, there are very, very few reports in the literature, particularly in the pediatric literature, in young infants and children where you can have some air embolism with it. But again, very, very unlikely. But either way, particularly if you have a younger patient or a patient with kind of poor reserves, screening for the presence of a right to left cardiac shunt can help to make it a safe procedure. As I'm sure you guys may be aware of, air is not your friend when you're doing an MRI arthrogram. So I would not I would not advise doing an air arthrogram when you're going to be following it up with an MRI. All right, so moving from glenohumeral injections to arthrograms, again, sticking with fluoroscopic guidance, we've got another image here. So you're called by your MRI technologist and they ask you to check this shoulder arthrogram image. So based on this coronal T1 image provided, what's going on? So A, there's too much gadolinium. B, not enough. C, we added steroids when we weren't supposed to. Or D, everything looks normal. I'm going to come on over to our Poll Everywhere. Okay, so it looks like we've got a nice split between too much and not enough gadolinium. I like it. We'll chat about this in a second here. This is a case of too much gadolinium. We have a companion case here. So same thing, MRI technologist is going to call you, check these images. We have coronal T1 fat suppressed images this time, and they want to know what's going on. They can't see the contrast. So again, did we put too much gadolinium? Not enough. Steroids are in the injectate, or everything looks good. All right, we led you with our first one. So great. So this is a case of not enough gadolinium in the injectate. So not to go over too much of the physics of arthrogram solutions, I found some nice examples of kind of why we inject the gadolinium concentration that we do. And so what the images on the left are showing you is from left to right, they took test tubes and they put in increasing concentrations of gadolinium, and your top images are T1 weighted and your bottom images are T2 weighted. And you can see on the T1 weighted images, you kind of have a bell curve as far as low signal, and then you get higher signal as you increase your gadolinium concentration, and then it dips back off as you increase it further. In contrast, your T2 weighted sequence, you have high signal with lower gadolinium, and then that decreases as you increase it. So if you kind of plot out both the T1 and the T2 sequences, what we're trying to get is a concentration where you get a decent amount of signal intensity on both the T1 and T2 weighted images. So that's kind of at this intersection point, which is at a concentration of 1 to 200 of gadolinium. And that equates to about 0.1 mLs per 20 of gadolinium per 20 ml injectate, which is a very common arthrographic solution. So again, arthrogram solutions, again, a very kind of busy slide here, but focusing on our shoulder, what we'll typically do is give 20 mLs of non-gadolinium. And for shoulders, we'll usually do 10 mLs of lidocaine, 5 mLs of omnipaque, so you can see it on the fluoro, 5 mLs of saline, and then 0.1 of GAD, which gives you that 1 to 200 concentration. Also listed CT arthrogram contrast here as well. All right, so moving away from fluoroscopic guidance to ultrasound guidance, we'll take a look at glenohumeral joint injection technique. So we're going to look at anatomy first, and I'm wondering to know what the structure is labeled by the asterisks here. So we have the humeral head, the glenoid, labrum, or the long head biceps tendon. Okay, we're going to go ahead. We don't have the image here, but you can go ahead and put your answers in. All right, so perfect. So that's a case of, this is our labrum. So going over our shoulder anatomy, I know not everybody does a ton of musculoskeletal ultrasound. When we're scanning the glenohumeral joint, we're typically going to do it from a posterior approach. So if you look at this image on the left, you can see kind of cross section, kind of an axial cadaveric view, and then our transducer and where we have the transducer when we're doing these injections. So overlaying our anatomy on top of our ultrasound image, you can see the bony landmarks of the humeral head on screen left, the glenoid on screen right, and then superficial to that, you have the yellow labrum, which is one of the things that we don't want to hit with our needle as we're doing these injections. And then superficial, we have the infraspinatus and then the deltoid when you're counting kind of those anatomic layers. So ultrasound guided glenohumeral injections can either be done from a medial to lateral approach or a lateral to medial. I often find that medial to lateral is kind of the most straightforward, where if you go ahead and kind of insert your needle along this trajectory, you can just touch down to the humeral head, very similar to your fluoroscopic guided injections. So you have that kind of tactile feedback, knowing that you're where you need to be. Once you're there, you can go ahead and inject your lidocaine, which allows you to make sure that you're intra-articular. And as long as everything's flowing away from the needle, then you can go ahead and do your steroid mixture. But again, you want to just make sure that you stay above that labrum, which is that yellow star.
Lindsay, I had a question for you. And I also wanted to just pause and say, if anyone has questions on anything we've covered so far, please feel free to put those in the Q&A and we can get those answered by Dr. Stratchko. But while we have a moment, I had a question. First of all, I'm glad to see you're in the medial to lateral camp because that's how I do mine. And I find it easier like you do. I know in the literature, a lot of the articles on it show it lateral to medial, but I know many of us here prefer medial to lateral and find it straightforward. But my question, everything else being equal, if someone asked you, hey, I'm getting a shoulder injection, should I have it done under fluoroscopy or under ultrasound? Do you have a recommendation? Do you have a personal preference? Are they equal? What would you say with regards to that?
So I think a lot of it depends on patient factors. So if a patient has a really hard time maintaining a positioning for a fluoroscopic injection, then an ultrasound guided injection may be more tolerable for the patient. They don't have to have their arm in external rotation or supination. Oftentimes that can be more comfortable. If a patient's particularly needle phobic, they don't have to be looking at the needle if you have an ultrasound guided injection. Typically for a lot of patients, unless they're pretty thin, you're going to have to use a longer needle when you're doing an ultrasound guided injection, just because you're coming at an oblique course because the transducer's there. So you do have to traverse a little bit more tissue. I don't have a specific preference. I feel like a lot of it just depends on kind of patient positioning, whether or not you think they'll be able to tolerate one versus the other. Is kind of how I deal with that.
Yeah, that makes sense. I've had patients be really nervous about radiation and want ultrasound for that reason. Of course, we know that the radiation dose for a fluoro injection is really, really small. I think the positioning piece is a big thing too, because ultrasound is so flexible. I mean, for any location, right? So that's a really good point. Let me hit you with a couple questions from the audience. One is with regards to contrast volume for the arthrograms. And so the question is, does 12 to 15 milliliters tend to over distend the glenohumeral joint? What are your thoughts on sort of the appropriate volume, and how do you monitor that for any individual patient?
Yeah, so I typically will inject about 10 to 12 mLs, typically closer to the 12 ml. Oftentimes I'll take an injection or an image, obviously confirming that the contrast is intra-articular. And then as I'm nearing the end of my contrast mixture, or if I'm feeling resistance more so than I think I should for the volume that I'm injecting, I'll take a peek just to make sure, one, the needle hasn't moved and come out of the joint or anything, but then two, it kind of allows you to be able to see the distension and to make sure it's adequate. I find that oftentimes, that 10 to 12 mLs is a really adequate amount. Certainly if a patient has, like I said, adhesive capsulitis, you can get a lot more resistance with your injection, and you may not be able to get quite the same volume in. But outside of that, I think that that's typically a reasonable volume.
That 10 to 12, that makes sense. I know I've had patients tell me they're very sore the day after an arthrogram. So I think there is a consequence with you distend too far. The other question that we have from the audience is, do you change your setup at all if the patient is post-operative? So if they've had a cuff repair, a Allergy procedure, a biceps tenodesis, how does that influence your approach? If it does, do you change anything for that?
Yeah, so typically my approach is going to be very similar. Oftentimes, particularly if you're using a rotator interval approach, you can still maintain a same approach and trajectory, even on patients that have had, a superior cuff repair or, any rotator cuff repair, because presumably when you're in the rotator interval, you're not going to be traversing those tendons. Biceps tenodesis makes it a little bit easier for you, right? Because your biceps tendon is no longer in that rotator interval, so your likelihood of hitting it is less. But again, outside of, as long as patients can hold that position okay, I usually will keep my approach the same.
That makes sense. All right, and then we have one One last question for you. Is there any risk for the needle to break inside the joint? For example, if the
Oh,
patient were to rotate internally?
yeah. I mean, I think that they would have to exert a lot of force for that to happen. I've not heard of it happening. Thankfully, I've not experienced
Yeah.
that at all in my
It's only
practice.
happened to me like 3 or 4 times, so it's very
Yeah,
uncommon. No, I've never had it
very.
happen either. So now I'm
Um,
nervous about it that the question's
I
out
know
there,
right
right?
now,
But
I
yeah.
think that, so I think one of the pros of this injection is a deeper injection. We use a particulate steroid. So as a consequence of having to use a particulate steroid, you have to use a slightly larger needle. So if you were doing a superficial injection and using a non-particulate steroid, so like a dexamethasone, you can inject that through a 27 gauge needle. I don't know if anybody's had the pleasure of trying to inject Kenalog through a 27 gauge needle. Spoiler alert, it's not great. So by a consequence of that, you're going to have to use a larger needle, which I think would maybe give you a little bit more stability, decrease the risk of any sort of fracture. I would think that it's very rare though.
Yeah, I've never heard of it happening, but now I have a new thing to be nervous about. But I think that'd be very unlikely. Let's let you move on for now. We got a couple more questions coming in, and keep them coming into the Q&A, and we'll pause again a little bit and look at some of these other questions in a moment.
Yeah, great questions, guys. All righty, let me see if I can get back here. Okay, so another question here. So you're consulted by the emergency department for a patient with shoulder pain, fevers, and leukocytosis. They're requesting a glenohumeral joint aspiration based on the images that are obtained on the right. What is your best course of action? A is nothing, it's a normal MRI. B is a fluoroscopic guided glenohumeral aspiration. C, ultrasound guided glenohumeral aspiration. D, ultrasound guided subacromial subdeltoid bursa aspiration. Or E, both glenohumeral and subacromial bursa injection under ultrasound guidance. All right, so the majority, so slightly split, but the majority went with an ultrasound guided subacromial subdeltoid bursa aspiration, which is what I would do as well. So without further ado, we'll come into our ultrasound guided approach for subacromial bursa access. So one, I think it's important to kind of define your anatomy under ultrasound. Again, this wasn't something that I think that everybody's super familiar with, depending on your ultrasound exposure. So when we're counting the layers of our kind of superior cuff and shoulder evaluation with ultrasound, the most superficial layer you're going to get to is subcutaneous fat. Beneath that, you're going to have your deltoid. Underneath that is going to be your subacromial subdeltoid bursa, which is usually you're just going to see an echogenic peribursal fat layer rather than actual fluid within the bursa, unless it's abnormal. Beneath that, you're going to have your supraspinatus tendon, followed by your cartilage, which is going to be a thin hypoechoic layer, which is over top your humeral head. So now focusing more on that subacromial subdeltoid bursa, when there's abnormalities associated with the bursa, you can have thickening fluid distension of that bursa, which is outlined in red here. And you can again see that it's superficial to that supraspinatus tendon, but deep to the deltoid. So this was a case of the one that we had in our question was a case of subacromial subdeltoid septic bursitis. And it's important, although it can be challenging, to distinguish from septic arthritis. And the reason being is that depending on your approach, you could traverse through the bursa to get to the joint. It's also important to note if you have a patient that has a full thickness rotator cuff tear, just like our case before, the joint and the bursa will communicate. So you have to assume if one is infected, then the other potentially will be as well. And you can see the images here, which is our grayscale subacromial subdeltoid bursa image on the left. On the right, you can see there's marked hyperemia surrounding that bursa. And then you can see that the needle is coming in from a kind of screen right approach when an aspiration was performed, and it was confirmed to be MRSA within the bursa.
So a question for you with regards to this case, when you get a request for a glenohumeral aspiration, which is sort of how this case came across, we often don't have the MR. what imaging do you request, if any, or do you just proceed with the joint aspiration? Especially, a lot of these come in after hours and are somewhat urgent, and you don't necessarily want to delay with imaging requests. What's your approach for stuff like that with imaging before an aspiration?
Yeah, I think that's a really great question. And I think it can be challenging to answer because I don't know that there's always 100% a right answer. So one thing that I try to make sure of before I do an aspiration is to make sure orthopedics has seen the patient, just because I think that there are some physical exam clues that can point you towards a septic bursitis versus a septic arthritis. So particularly if a patient has like superficial swelling or erythema, sometimes they can get fluctuance beneath the skin because, again, it's a more superficial structure, or even some like skin discoloration, depending on how distended and taut that bursa is. I think that patients can certainly have shoulder pain with a bursitis or a glenohumeral septic arthritis. Typically, though, the range of motion can be preserved, as you can imagine, because it's not a joint-centered process with a septic bursitis, whereas you can have limitations in your range of motion with an arthritis, septic arthritis. So long answer to that question. I don't necessarily always require imaging, but I do like to have orthopedics input on it. And if there is any concern about what the source may be, then I think imaging can play a really important role to kind of help you determine what the best kind of next step regarding intervention is.
I think that makes sense. And I'm glad to hear you don't have the right answer, because I've been hit with these requests and not been sure what the correct answer is. Sometimes I'll call ortho and we'll talk it out, and the right answer will come out of that discussion. Or if it's during the daytime, sometimes I phone a friend. I know I've done this to you, or I call and we have a chat, and sometimes you get some good ideas just bouncing off another person. I think it can be a reason to use ultrasound for the aspiration, I found, because then you can have the diagnostic ultrasound and then the guidance for the joint aspiration all at once, as you're kind of alluding to. So that's another solution. But I'm glad I'm not the only one who struggled with that. So
yeah, it can definitely be challenging for sure. Okay. All right.
Oh, and sorry to
yeah.
interrupt. I had just one question that popped up that's right on topic here. And so if the patient has a known full thickness rotator cuff tear and there's concern for septic arthritis, do you need to tap both the glenohumeral joint and the bursa, or can you just tap the joint?
Yeah, so for those cases, what I'll typically do is tap the joint, or if you do have imaging and see that the majority of the fluid is within the bursa, I'll go to wherever the fluid is, but there's usually not a reason where you would have to do both of them if the patient has a known full thickness superior cuff tear, because you know that those spaces will communicate. So again, kind of the less intervention at that point certainly is going to be more comfortable for the patient to not have to undergo two aspirations. So I'll typically just do one site.
Excellent.
All right, so you guys did a great job on all the cases. Hopefully after this webinar, you have an increased understanding of image-guided shoulder injections, including both glenohumeral and subacromial subdeltoid injection and aspiration, as well as shoulder arthrograms. And hopefully with some of our tools, you've kind of improved your knowledge of both fluoroscopic as well as ultrasound shoulder anatomy. So again, these are just some references. I'm more than happy to answer any additional questions. If you have, go ahead and leave them in the Q&A. And again, we appreciate your time and your participation.
Thank you so much, Dr. Stratchko. That was just a fantastic presentation. I just feel like we were really lucky to get you here to do this for us. And I encourage people to reach out to Dr. Stratchko if you have more questions. Let's just take a quick look at the Q&A and see if we have any final questions here. One question that was asked, going back to something you talked about earlier with regards to volume of injectate for arthrograms. What are some other key? Can you just speak more to some other cues that you use to adjust your volume during the arthrogram with regards to resistance or the appearance on fluoro? That seems to be a consistent question here for a few people.
Yeah, that's great. So, like I said, I think it does take a little bit of a couple injections and a couple arthrograms to get an idea of what a normal joint resistance should be when you're injecting. And then as you inject, certainly as you're descending the joint, you're going to be able to feel some increased resistance. What I'm looking for typically on my arthrogram images when I'm taking a fluoroscopic image is, one, you want to have distension of your joint, your axillary recess. Oftentimes you're going to have some contrast that extends into that superior subscapularis recess, which is going to be kind of that medial directed contrast that goes underneath the coracoid process. One of the things that I think you have to be cognizant of is if you have a lot of resistance and then a loss of resistance, that would be a cue to check your images, because sometimes you can have like extracapsular leak at that point in time. So you're looking for more of that kind of streaky contrast pattern that's extending outside of the confines of what you would expect that axillary recess and superior subscapularis recess to be. The other thing you may also run into is if a patient has a large rotator cuff tear that you're not expecting, that resistance that you're expecting to increase may not, because you have a more capacious space that you're filling. You've got both a joint and a bursa that you can fill. So that's another reason why, like when I'm getting close to that 10 to 12 mLs, it's always nice to step on fluoro. And if you see all this contrast that looks like it's extending outside of the joint, one, you have diagnostic information that there's a cuff tear, or two, you know that you're probably not going to get the same volume of distension that you would with a patient that has an intact joint, intact rotator cuff.
Those are great points. And I think it takes experience, exactly like you said. So it's nice to have the opportunity to pick the brain of someone who does have a lot of experience. Well, we're right on time here to wrap up. So I want to thank Dr. Stratchko once again for such an excellent presentation. That was really enjoyable. And I also want to mention that the next webinar through the SSR's Resident Education Club is going to be November 17th. It's at 7 p.m. Eastern time. You can get the information on Twitter or off the SSR website. So keep an eye out for that. And we're going to have Dr. Megan Mills from the University of Utah presenting on orthopedic implant complications. So she's an outstanding radiologist, a great presenter, and that's a really challenging topic. So hope to see you guys there. Also, we'll be sending out an evaluation link in email. And if you can take the time to fill that out, we just really appreciate getting the feedback so that we can continue to improve these webinars and make them as valuable as possible. But once again, thank you everybody for attending, and have a great evening. It's great to see you all here virtually.
Yep, thank you again.